Without wasting much time, I'd like to invite Dr. Anjali Gupta to give a talk. She's a senior consultant histopathologist at the Department of Pathology at M.I.C.E Speciality Hospital, Saket, New Delhi, India. Over to Dr. Anjali.
Hello, good evening. I just have to share my screen. I'm Dr. Anjali. Thank you, sir, Dr. Sehgal and Dr. Gupta and team for giving me this opportunity to speak among these eminent speakers. The next slide, of course. I have to keep saying this, I guess. Well, uh, sorry. Rejection of transplanted organs is the worst nightmare of any transplant surgery. We all understand that. And I'm so sorry, I have to keep saying,
no problem.
Okay, this is better. I think this is better. Uh, well, we can all see that rejection remains one of the main causes of early graft dysfunction in all post-transplant cases. So the next.
You should help. You should
I'm
help
so
me
sorry,
out
the
by
next.
giving early reports in the hospital. Right? I'm helping you in this.
Yeah, definitely,
Okay.
definitely. I want the second. You can just scroll through the. Here I need it to stay for some time. Before embarking into the pathology, let's see what a normal allograft liver biopsy looks like. So we have, thank God I have just, marked it very well. CHV is the central hepatic vein. LP is the lobular parenchyma. PV is the portal vein. BD is the bile duct. PT is the portal tract, and HA is the hepatic artery. So this is what a normal allograft looks like, allograft biopsy. You can see here that the portal tract is pretty clean, it's pretty neat, and there are no portal infiltrates per se in this biopsy. The lobular parenchyma is also pretty neat, two-cell plate thick, which is of course normal for all allografts, and central hepatic vein as it is pretty clean as well. Next slide. Next slide, sir. Okay, so now that we are talking about rejection, it is of two types, the antibody mediated and cell mediated. So first I will discuss the cell mediated rejection, which are of three types. Acute T cell mediated rejection, nowadays it's just called TCMR. Late acute T cell mediated rejection with atypical features, and chronic T cell mediated rejection. Next slide, sir. So T cell mediated rejection is not based on time of occurrence from the transplant, but on characteristic histomorphological changes. And the factors determining the incidence are site of transplant, time of immunosuppression, perioperative factors like ischemia, infections, type of post-liver transplant surveillance, and the donor characteristics like age, living versus dead, etc. The next slide. Well, uh, before, this is a small diagram which I had made, it shows the pathophysiology of T cell mediated rejection. T cell mediated rejection is immunologically mediated. So the recipient T cells, which lie on the left side, they usually recognize the alloantigens of the donor liver, that is, which are concentrated in the bile ductular epithelial cells as well as in the endothelium of the portal veins and central hepatic veins, and hence destroying them. Next. So hence what happens is these portal infiltrates, the inflammatory infiltrates are typically found in the portal tract as well as around the central hepatic vein. So there's a Banff scheme for scoring of rejection activity index from zero on a scale from 0 to 9, which is based on the amount of portal inflammation, bile duct injury / inflammation, and the venous phlebitis. This is there in many literatures, so you can just have a look up. Mild rejection being 3 to 4, and severe rejection being more than 7. So let's have some case-based discussion. Here we have a 53-year-old male, NASH rated CLD post LDLT 70 days back. Donor was his 23-year-old son, presenting with increased transaminases, alkaline phosphatase, serum bilirubin. Viral markers were negative. Background check revealed a GRW of 1.16. So it rules out SFSS. Next slide. So this is what the bilirubin and AST, ALT looks like on post-op day 20 and post-op day 70. So we can see here that the bilirubin it has come down, and again it has gone up to 6, and similarly. And radiology, next the radiology of course was done, and there was no increase in, no IHBRs, so it rules out biliary stricture, no vascular flow disturbances, so it rules out any flow disturbances, vascular flow disturbances. Next, a core needle biopsy was done. So next, please. In the next, I have kept on the left side is a normal one for comparison, and on the right is what we got from the patient. So here you can compare these both biopsies. The portal tracts are definitely expanded by this inflammatory infiltrates, and the lobular parenchyma looks pretty normal. It's in comparison, except that this is a slightly more stained slide. The lobular parenchyma is pretty normal. Next slide. Well, this is a higher power view of the portal tract on the left side, which shows a totally busy portal tract. It's filled with inflammatory cells, mostly lymphomononuclear. Few eosinophils are there, and few plasma cells, very few. And there is a definite ductulitis. I mean, the green arrow here shows the lymphocyte inside the bile duct epithelium. There is some amount of morphological disarray going on in the bile duct. There's nuclear dysmorphy and some amount of hyperchromasia and eosinophilia. And sorry, again, the same slide I still not finished. Well, so here we have to note one thing, that there is no, I mean, the portal parenchymal interface is pretty preserved. There is no spill into the surrounding parenchyma. The central vein here shows some amount of phlebitis. There are a few inflammatory cells just underneath the endothelium. The next slide, please. And so a diagnosis of acute T-cell mediated rejection activity index of 7/9 was made on this case. The next case, of course, is again, oh well, here's a cliche. The tacrolimus level, as you can see on day 20 and day 70, is definitely much lesser than the therapeutic level. So we got the history that the patient had reduced his doses of tacrolimus. So therefore, he had come up with this acute rejection. Next slide. Going back to the case 2. Going up front to the case 2, we have a 44-year-old male with, again, the NASH-related CLD. But this one was post-DDLT 5 years, presenting with nausea, yellowish discoloration of skin, no itching. Lab work revealed increased transaminases and bilirubin. Alkaline phosphatase DGT was not significantly increased. The viral markers were negative. Background check, well, he was treated for biliary stricture about 2 years back. The next slide, please. Can I have the next slide? Yeah. The radiology showed normal biliary and vascular flows. Core needle biopsy was done. The next slide, please. Well, again, the left-sided biopsy is for comparison. Here we can see that the portal tracts, PT is the portal tract, it is filled with inflammatory infiltrate, and there is no portal parenchymal, there's the clean margin around the portal tract has been lost here. Even the lobular parenchyma looks pretty, infiltrated. Central vein looks, it's not very clear here. I'll show it to you in the next slide. Can I have the next slide? Sorry. Yeah, this is the higher power view of the portal tract of the same case. It is showing an interface activity, and the infiltrate is mostly monomorphic, it's mostly lymphocytes. And there is a definite ductulitis where I have pointed with the arrow with loss of its architecture. There is portal vein phlebitis. The next slide, sir. And here is the central vein, and there is significant perivenulitis and associated lobulitis on the right side. There's quite a bit of lobulitis on the 10x view of this allograft. So next. So with these features, late acute T-cell mediated rejection with atypical features was made. Again, the rejection activity remains same, 7/9. The next slide. While diagnosing T-cell mediated rejection, we have to rule out viral infections, recurrent or de novo. De novo non-viral, non-infective hepatitis like autoimmune hepatitis, drug-induced hepatitis, and post-transplant lymphoproliferative disorders, because these have very overlapping and similar features. So we have to rule all these things out by other means, serology mostly, or other clinical. Okay. Thank you. So we have come, so that is all about T-cell mediated rejection. And now we come to antibody mediated rejection. Antibody mediated rejection is very rare, as Dr. Levinsky had just said that the liver has a great immune tolerance, so it's an immune privileged organ. But still, these are the types of acute antibody mediated rejection we have seen: hyperacute, acute, and late onset acute AMR, which is in the post 6 months post LT. Chronic AMR is there, and there is a plasma cell rich rejection, which some of the speakers have already spoken about. The next slide. Well, this is the pathophysiology, which I have tried to put it in a small diagram. It can be explained by a two-head theory, actually. The first head being T-cell mediated rejection, hepatitis, ischemia, reperfusion injury. This all gives rise to the first head, which upregulates the class 2 HLA antigens in the liver, which then combines with the circulating DSAs, or donor-specific antibodies, and then this activates the classical complement cascade and facilitates cellular cytotoxicity through the Fc receptors, and then leading to the second hit, which leads to the severe graft injury. Next slide, please. Hyperacute AMR is very rare outside of ABO mismatch in liver transplant. It's rarely seen, in fact, and presents immediate as post-perfusion hypotension, coagulopathy, progressive hyperbilirubinemia, renal failure, and refractory thrombocytopenia. And pathology receives an explanted failed graft, or sometimes we don't even receive it. The next slide. These are some of the slides which I have taken from the internet. I'm sorry. It is a slide of hemorrhagic necrosis. I mean, the liver should, on microscopy, would look something like this, which is on the 5x view. Severe hemorrhage and necrosis. The next slide. Acute AMR. Now, acute AMR presents as a graft dysfunction 1 to 2 weeks post liver transplant. Clinically, it gives, there's a rise in GGT, transaminases, and the serum bilirubin. And in 2016, there was a reclassification by Banff, and where in the Banff committee, where AMR diagnostic criteria was based on histopathologic score, C4D immunohistochemistry scores, DSAs, and exclusion of other diseases with a similar pattern of injury in the liver. The next slide. Well, this is fine. This is some of the criteria which acute AMR looks like. There is endothelitis and hypertrophy of the endothelium with mixed portal infiltrate, which is mostly composed of neutrophils, eosinophils, lymphocytes, plasma cells, and a lot of phlebitis, portal vein phlebitis. The next slide. The next slide. There is portal and periportal edema along with endothelitis. This is just a higher power view. The next slide. Other portions of the liver shows biliary stasis in the form of bile plaques. Ductular reaction is prominent because the liver is dining. It's a stem cell reaction. Next. And C4D staining, though I have not seen much of this coming true in real life. There is diffuse deposition of more than 50% of portal tracts and more than 50% of the circumference of the venule or whatever vessel it is looked in. So in ABO compatible, it is mostly around the next previous slides. In the compatible, it is mostly perisinusoidal staining, and in portal veins as well as septal venules, as well as in other places where we get capillaries. Next. And in abio incompatible, we have portal stromal tissue staining and abio and portal venule and peribiliary staining. Next. I think we are running out of time. Next slide, please. I'm just finishing it. Hello. The next slide, please, sir. Okay, I wanted to speak a bit about DSAs, but it's just that I think accurate diagnosis of allograft biopsy interpretation is totally dependent on correlation of histological features with clinical imaging and laboratory findings. I think it was a much rushed up discussion. Thank you so much.